Welcome to the annual recurrent training video for the Hamilton T1 ventilator. The Hamilton T1 ventilator is an ICU grade ventilator set up for the transport environment. As a reminder, even though it's set up for transport, it is still a delicate piece of equipment, and drops, bangs, or crushes will hurt the ventilator. On the front of the ventilator, you have the carrying handle, which should be utilized at all times. The status bar, an alarm bar, which show you active alarms. Yellow is low or medium priority alarms. Red is for high priority alarms. You then have the screen, which is a touch screen. In the bottom, we have the battery compartment that is held together by small magnets here and here. Battery 1 is hot swappable. To do so, simply lift this, pull the battery out, take your new battery, slide it in, and lock again. When pushing here, it gives you the status of the battery. Slide in and lock. Battery 2 is not hot swappable and is covered. Close this to seal, the magnets will click. When turning the vent to the side, you see on top the communication ports. Only the older style ventilator will have the communication ports, the newer ones will not. Below, you see the yellow hookup, which is the nebulization. We won't be using that. We'll use the Aerogen device. Please see the separate video. Then you have your flow sensor connections. Blue goes to blue and white to white. It is important to remember that these must be seated deeply onto the connection ports, otherwise they can come off and cause problems. We then have the inspiratory port and the expiratory port. Please see the pictures for what goes where. This is your external speaker. To connect the tubing, start with the expiratory valve. It is imperative that the membrane is firmly seated on the valve. If you run into problems with either the flow sensor or failing the tightness check, please make sure that the membrane is on properly. This slides in, turn clockwise to lock. The tubing then slides on to the inspiratory and expiratory valves. Again, it's important to make sure these are well seated. Check your connections for blue and clear one more time, and the tubing has been connected. When looking at the back of the ventilator, you see the prongs that hold the vent either onto the stretcher or when you do hold it, the mount that goes on the center cabinet and the ECs. Behind the mount is a air intake. That filter only needs to be changed if it gets visibly soiled. We have our LAN connection for connection to a computer. If you need to do a software download, please contact your event specialist or reach out to either myself or John Rowland, and they can walk you through the service log downloads. When turning the vent all the way around, we have our high pressure oxygen hookup. We have installed a 90-degree elbow to make it a little more ergonomic and to not have the high pressure oxygen cable shooting straight out. I highly recommend the 90-degree elbow. Below that, we have the low pressure oxygen hookup, which we will not be using. All the way at the bottom, we have our power cord connection. This slides in right here and is used to power the ventilator. The cord wraps around here, and we have another air filter that again only needs to be changed if it gets visibly soiled or with PM. We have our 12-volt adapter here at the bottom. Here on the front of the screen, we have our control keys and our control knob. The first button is the power button. Press and hold to turn on. Press and hold to place in standby. You must hold for 3 seconds after that to turn it off. Below that are our battery status indicators. When the vent is plugged in, these two lights will be green. If they're solid green, that means it's plugged in and charged. If it's flashing green, that means that respective battery is charging. Below that, we have the day-night key, screen lock and unlock key, manual breath or inspiratory hold, increase FiO2. In adults, this increases the FiO2 to 100% for 2 minutes. In the neonatal mode, this increases the FiO2 by 25% for 2 minutes. For example, if the child was on 50% FiO2, it would be increased to 75% FiO2 for 2 minutes. Screenshot key. Nebulization key. Again, we will not be using the nebulization function on the ventilator. Please see the different video for the Aerogen device. Alarm silence key for 2 minutes. This is the scroll and select wheel. Simply scroll to whatever you'd like to pick, click to select. The screen, as a reminder, is also a touch screen. Starting at the top, we have the red I. That indicates that we had an alarm present, but the alarm is no longer active. If we click the I, it brings us to this screen, which shows us our most recent alarms. Because we do not have the alarm active anymore, we can hit reset, which gets rid of that. If we go to modes, it gives you a list of all the modes. Please see a separate video for a delineation of the modes. The top right corner shows you the current active mode. For us, it's adult pediatric CMV+. Over here, it shows a standby. We can either select neonatal, adult ped, or last patient. Just as with the Revell, we recommend not using the last patient, as no two patients are exactly alike. When the adult pediatric expiratory valve is on, and we select neonatal mode, it brings us this alarm, wrong expiratory valve. We simply need to select adult pediatric, and that will get rid of the alarm. Just as always, if we click the I, it shows us wrong expiratory valve, that alarm is no longer active, we can reset. Under adult peds, we have the 3 standard modes for the Hamilton. Adult scene is set up with CMV plus for 6 cc's per kilo of a 71 kilogram patient. We have a non-invasive feature, which is 10/5. As a reminder for BiPAP, this is additive. 15/5 would be the total. And an adult CPR mode, which we'll go into a little bit later. These 3 modes are meant to get you started when quite busy. We should not rely on these, as the cookie cutter modes will not be one size fits all, but this is a place to get you started. Below these modes, we see the male-female selection and then the height. It is imperative to correctly select the height and gender of the patient, because that gives you the ideal body weight and the correct cc's, 6 cc's per kg ideal body weight, so we use lung protective ventilation. The bottom, we see the preoperative check. Then the start ventilation key. We'll go into the preoperative check in a minute. Coming to the right, again, we have the mode that's currently selected and the 3 most common variables when used to change using that mode for CMV plus, tidal volume, PEEP, and FiO2. Below that, it brings us to the control screen. This is where you make adjustments to things like respiratory rate, PEEP, or tidal volume. If we go under more, it brings us to PRAMP and some other variables like ETS, depending on what mode you're in. Again, see the other video on modes for more in-depth information. Just as a general aside, the PSI key, when in a volume-controlled mode, the PSI key gives you 150% of your tidal volume every 50th breath, and when in pressure-controlled mode, goes up to 3 below the high-pressure limit every 50th breath. So for our use, it's not really relevant, forgive me. If we press the alarms key, it gives us our alarms. Now these alarms are for CPR mode, and so they do look a little strange. The pressure limit, expiratory minute volume, respiratory rate or F total, tidal volume, apnea time. If we look on limits 2, it's grayed out right now, but it's the oxygen sensor, okay? There is this auto key that is grayed out because we're not ventilating, but recommend against hitting the auto key because you really want to personalize your alarms to the individual patient. The auto key seems attractive, but if you use the auto key, it changes all the alarms at once. And so even if you just wanted to change the respiratory rate alarm because they were coughing, it's going to change all of the alarms. So you may not know that your tidal volume alarm went all the way down to 2 or something like that. So you have to be very careful when pressing the auto key. If we come over to tools, it allows us to select high pressure versus low pressure. We are only using the high pressure. If you go over here to configuration, it allows you to enter a code to change some standard configuration settings on the ventilator. This is up to the vent specialist to do. Events shows us the last 1,000 events on the ventilator. If we click the scroll wheel, it allows us to scroll through the last 1,000 events. I say this as a warning. The vent knows everything you did and did not do. The vent is smarter than we are. It knows. If we press system, it gives us the info, the serial number, the time, the hours used, the hours left to PM, capacity of the batteries, and all the options we have selected. Test and calibrations shows us the preoperative checks. Tightness check, flow sensor check, O2 cell. Again, we'll get to those in a second, and the last time they were performed. The green check mark indicates that the test was passed. A red X would be shown if the test had been failed. If we go to sensors, it gives us the O2 cell. I recommend leaving the O2 cell sensor on. Settings, you can change the loudness of the alarm from 1 all the way up to 10. Day-night mode. Day-night mode. Ours is set to automatic. Most are set to automatic. If not, you can press the day-night key over here. And changing the date and time. It is imperative to change the date and time with daylight savings time or not. The vent requires the time to be set accurately. Down here in the bottom corner, we have the battery status indicator. Battery 1, battery 2, and the little AC plug showing that the vent is not plugged in. Next, I want to talk about the tubing and the pre-operational checks. The tubing here at AirCare 1 is pre-connected. The tubing doesn't always have to be pre-connected, but some of the benefits of having it pre-connected are it's set up and ready to go should you get a scene flight or quickly need the ventilator. Remember that this tubing, the adult pediatric tubing, is good down to 3 kilograms. The cutoff that we're using is 10 kilograms for the neonatal tubing versus the adult pediatric tubing. That is in reference to the best practice guideline put out by Hamilton. In a bind, the neonatal tubing will go up to 30 kilos as well. But 10 kilos is the cutoff. Remember, when using neonatal tubing, you need to select neonatal mode using the neonatal expiratory valve. With the tubing pre-connected, one needs to do the pre-operational checks. To perform the pre-operational checks, on the main screen, you press pre-op check. The first is the tightness check. We press tightness and follow the instructions on the screen. This is a training circuit, but if you are using a new fresh circuit, please use a gloved finger to do so. This is past the test as indicated by the green check mark. Should you fail the tightness check, please make sure that all your connections are tight, including your flow sensor tubing lines, and your expiratory membrane is properly seated. The next test we're going to do is the flow sensor test. In order to do so, we use the dongle that comes with the new set of tubing. Insert the dongle into the flow sensor, hit flow sensor to begin test. Follow the instructions on the screen. Turn flow sensor. It'll say maneuver in progress and slowly ramp up the flow. Similar to the tightness test, if this test were to fail, check one, the flow sensor and the flow sensor connections, which should be deeply seated on their connection. Then check the rest of the tubing. Should it continue to fail beyond that point, please replace the flow sensor. We now can turn it one more time, and it'll continue the maneuver. The test has been passed, indicated by the green check mark and timestamp. We can now reseal the tubing. When setting it up for a patient transport, make sure to utilize the end-tidal CO2 detector as well as an HME. There is no literature-approved way to set up in which order this is set up. My personal recommendation is to follow manufacturer recommended guidelines, which is the end-tidal CO2 closest to the patient, so on the endotracheal tube itself for highest accuracy, followed by the flow sensor, followed by the HME, and then the endotracheal tube. If you had the Aerogen device, you could put it between the two as long as it's in front of the HME as to not block everything out. There have been reports of especially with Velitri, the HME getting clogged, causing high pressure alarms. If you run into high pressure alarms after the patient's been ventilating fine for some time, please remember your doped mnemonic. Is it something displaced? Is the patient obstructed? Is there a pneumothorax or equipment failure? Is there proper sedation on board, etc.? But as you go through that mnemonic, please remember that the HME, if it gets clogged, can cause high pressure alarms.